Huh.
All right, I asked if I could play for him. The owner said it was impossible. It was far too dangerous. I suggested I just give it a try and see what happened. With extreme caution, they brought a China to the piano, which was placed in the mountains away from people. It reached out, and strung out stretched over the piano, and sniffed around my face. This colossal creature was standing free and restrained, seemed to be listening, and on his reaction, like the it was gentle with play for China from time to time over the months, but the piano was just a small part of getting to know him. Yes, but don't just relax by eat as much as he needs to in the way nature intended. I discovered the baby and very young elephants the fast ragtime or show songs. Old elephants like slow, expressive classical music. Elephants that have had stressful lives don't forget, and after a life of arduous forced labor, don't seek elements as friends, rather oppressors. I feel privileged to have the opportunity to play piano music.
Oh, God, watch this. Watch this. Watch this. This is a trash man, and I think this is a common practice.
Hare Krishna.
And things happen to good people.
I asked for strength.
Hi, I'm Vijay Venkatesh, Managing Trustee at Friends of Max.
How's the competition with Apple? Well, Android has way more users than iOS.
It's a great song.
I was. Complaining on the fifth day, the last over before lunch, they got an extra over. The England didn't do this. Gill is in their face. Gill's not happy. It was back here. We are from Bengaluru. You will find us.
Jitesh, I've made you the host, please.
Okay, sir.
You need to start recording, okay?
Yes, sir. Yes, sir. Okay, sir.
Bye.
Bye, sir.
No, 11 o'clock only I will start. Still 11 o'clock.
Bangalore better. Sir, can you please try to change slides, sir? Yes, yes, sir. Speak something, sir. We'll check the audio.
Okay. Good morning, ma'am.
Yes, sir.
Audible, Ramma?
Yes, sir. Yes, sir.
Okay, fine.
Good evening, sir. Yes, sir. Sir, you spoke with Banushree, ma'am. How is she now, sir?
Hello, ma'am. She's doing fine, ma'am.
Yes, sir. Yes.
Okay.
We'll wait for 5 minutes and then we'll start the
Okay.
session, sir. Hmm?
Okay, fine, ma'am. Fine.
Okay, sir, we'll start the session. We'll see how many more join.
Okay, ma'am. Fine, ma'am. I will
Hmm?
begin, ma'am. Okay, ma'am.
Yes, sir.
Yeah.
We'll do the chanting. Kavita is there.
Yes, ma'am.
Yes, ma'am. You will do the beginning and ending. Huh? Yes.
Okay.
Thank you, sir. Thank you, sir.
Okay, ma'am. Thank you. Uh,
We'll start with 70 Om thrice followed by the NMO mantra. Om. 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 नत्वहं कामये राज्यं न स्वर्गं न पुनर्भवम् कामये दुःखतप्तानां प्राणिनाम् आर्तिनाशनम्. Meaning, I do not seek kingdom, heaven, or even rebirth. My only desire is to remove the suffering of those in pain. With that, sir, you can start the session. Sir.
Okay.
Thank you.
Thank you, Kavita. At outset, I would like to thank Dr. Vanishri Madam for giving me this opportunity. On the aegis of a National Medicos Organization, you have this revision program. So I'll be teaching on CNS, genitourinary system, hospital infection, and zoonosis. So mostly I'll be covering the important questions that come as long answers as well as short answers. Right? To begin with, just a minute. So what I want to have a disclaimer is that it's purely the opinion, right? Learned opinion. I've been examiner in MGR University, RGHS, and Kerala University of Health Sciences, as well as NTR University. So based on my experience, I'm telling these are all the important questions and the answers expected. But however, it varies individual to individual. So nobody can tell for 100% sure this is completely required or anything. Most 70 to 80% are the required content for the questions. So let's look into the CNS. From the CNS, usually you have the long essays coming from the topics tetanus, rabies, neurocysticercosis, as well as toxoplasmosis. Sometimes some universities do even ask questions on meningitis. Meningitis in general, it could be neonatal meningitis or pyogenic or specific organism like meningococcal or pneumococcal meningitis that has appeared in the universities. Then you have the short notes questions like poliomyelitis, Japanese encephalitis, Nipah virus, prion disease, cryptococcal meningitis, free living amoeba, that is usually Acanthamoeba, as well as Naegleria fowleri. Coming to the urogenital infections, you have the long essays like urinary tract infections, syphilis, as well as HIV. So these, some of the topics sometimes certainly do not fall in one system alone. For example, HIV, it also comes under bloodstream infections also, depending upon the university. However, you got to know about this. Then you have short tests, mainly lymphogranuloma venerum, granuloma inguinale, herpes, chancroid, gonorrhea, trichomoniasis, bacterial vaginosis, candidiasis, scrub typhus. These are all zoonotic infections, plague, anthrax, congenital infections, as well as HPV. Fine. So let's look into the question now. This is a most often repeated question. So a 25-year-old man presents with just a minute. 25-year-old man presents with single painless ulcer over his genitals. On examination, the base of the ulcer is indurated. He gives history of unprotected sexual intercourse. So what is your provisional diagnosis? Discuss the pathogenesis in brief and add a note on serodiagnosis of this disease. Here, the catch line in the long question is a single painless ulcer over the genitalia. Painless ulcer is something which is catchy, as well as the ulcer is indurated. So this gives a clue. It could be a case of syphilis, and the diagnosis has to be written as primary syphilis. You know, syphilis occurs in 3 stages. So you have to write as primary syphilis. Many students write it as just syphilis, which may be partially correct. Okay. Because secondary syphilis, the features of presentation is something really different. Then you have discuss the pathogenesis in brief. So the expected answer for the pathogenesis in brief is you have to write the causative organism, that's a spirochete treponema pallidum. The mode of transmission is mostly through the acquired route. Sometimes in case of children, it could be congenital, but in this above case, it is mentioned in the history that there is a history of unprotected sexual intercourse. Therefore, the transmission is sexual. Other modes include the blood transfusion, rarely occupational through contact or handling the primary lesion, then congenital, that is through the transplacental. Coming to the course of the disease, so following the exposure, there is skin to skin contact or bacteria invades through the mucosa or the break in the skin. Usually it will be asymptomatic, resulting in bacteremia, incubation period of 1 month. Then you have the hard, painless, well-defined genital ulcers with exudates and localized lymphadenopathy, which is indicative of primary syphilis. This heals without treatment, or sometimes it progresses to secondary syphilis. The secondary stage of syphilis is characterized by skin rashes throughout the body with mucus patches involving the mucocutaneous junctions. Even the secondary syphilis also heals spontaneously without treatment. But after a duration of 4 to 5 years, there is a possibility of going in for latent syphilis. This results in tertiary syphilis, which will have cardiovascular as well as neurological manifestations. So if still not treated, it can result in quaternary or a late syphilis, which is known as Tape's dorsalis or generalized paralysis of the insane. This is in brief about the pathogenesis. Then coming to the laboratory diagnosis, you can see in the main question what is highlighted and asked is note on sero-diagnosis of the disease. So it is not asking complete lab diagnosis. So the explanation is limited only to the sero-diagnosis here. That is, you classify the serological test into 3 groups: non-treponemal, group specific, as well as species specific test. So non-treponemal tests are also known as the standard test for the syphilis. Then you got to list the names, that is Wassermann, Cons, tube, flocculation test, VDRL, RPR test, and trust. You need not explain all the test, but VDRL test, you got to write some things like a brief explanation about that. That is, what is the antigen that is detected. So usually it is targeting the looking for the antibodies against the cardiolipin antigen, which is a non-specific test. Therefore, it is regarded as a screening test. Then you got to write about the biological false positive reactions, right? What is biological false positive reactions and few examples for that. This is mainly antibodies targeting against the cardiolipin antigen that is present, which can be present in other disorders also. Fine. Then you have the species specific test, that is a confirmatory test for syphilis. These include antigens that is elicited from the Nicole strain of Treponema pallidum. 3 important ones include the TPI, that is Treponema pallidum immobilization test, Treponema pallidum hemagglutination test, and fluorescent treponemal antibody absorption test. So the most sensitive is the fluorescent treponemal antibody absorption test, and the specific is the Treponema pallidum immobilization test. Then you got to write about the sensitivity and specificity of the various tests. You can see in the table lower down that the sensitivity as well as specificity, here only the sensitivity is mentioned. It varies along with the stage of the disease, not only the type of the test that is being done. That is primary syphilis, the sensitivity is low for almost all the tests, whereas tertiary syphilis, the sensitivity increases, whereas it is 100% during the secondary syphilis. This is about the brief about sero-diagnosis of syphilis. So sometimes the question can also come with the history indicative of syphilis and asking like enumerate 4 bacteria causing sexually transmitted disease and lab diagnosis of syphilis. Here the difference is it is not asking sero-diagnosis, it is asking lab diagnosis. Here you got to indicate the samples that needs to be collected as well as the test that can be employed other than the sero-diagnosis too, right? So the common bacteria that are implicated in causation of sexually transmitted disease include Neisseria gonorrhoeae, Treponema pallidum, Haemophilus ducreyi, Klebsiella granulomatis, Cardinarella vaginalis, Chlamydia trachomatis, Ureaplasma urealyticum. Then coming to the lab diagnosis of syphilis, the samples that needs to be collected, depending upon the stage of the syphilis. In case if it is a primary syphilis, usually the patient presents with ulcers, right? So you got to collect the exudates from the ulcer. So it can demonstrate the presence of the microorganism, that is the spirochete. This can be demonstrated by dark ground illumination microscopy, wherein you will be able to see the corkscrew motility. Or you can use staining techniques like you can make a smear from the pus samples that comes out from the ulcers. You use Fontana's silver impregnations technique in case if it is a smear. If it is a tissue sections, that is if a biopsy is taken from the ulcer edge and all, you can use Lavaditis silver impregnation technique. So therefore, 2 silver impregnation techniques are used. But however, the sensitivity of this microscopic method is not high. Therefore, it is not popular. This is just of theoretical importance. But in case if lab diagnosis of syphilis is asked, this has to be mentioned as the first step. The next step would be the serological test, which is already been described in the first question, right? And coming to the next question, a 50-year-old lady with uncontrolled diabetes presents with increased frequency, urgency, and burning micturition since 2 days. So by the history, you can clearly make out the diagnosis, right? The age is postmenopausal. The gender is female with diabetes. So you have the 3 risk factor in this with symptoms of increased frequency, urgency, and burning micturition. Burning micturition is something which is clenching and it is of acute onset, that is since 2 days. So therefore, the provisional diagnosis would be here. It's a case of urinary tract infection. Okay, sometimes this question can be enriched by asking a hospital stay or a catheter in place. So in such situations, you got to write it as it is a hospital acquired urinary tract infection. If catheterized history is given, you have to write it as catheter associated urinary tract infection, that is COTI. Okay, here nothing that sort of a thing is there. It is just a community acquired urinary tract infection. So risk factors, I've already said, the few you can collect from the question itself is the age, then the gender, as well as the diabetes. Besides that, other risk factors we will see. So the same question can also come as like this. Enumerate the bacteria causing urinary tract infection. Add a note on pathogenesis, lab diagnosis, and antimicrobials of choice for uncomplicated urinary tract infection. This is the question without a history. Here it's a question with the history. Clear? So bacteria that are commonly implicated to cause UTI, you can divide it into gram-negative and gram-positive organisms. Mostly UTI is caused by gram-negative organisms, that is mainly the bacilli rather than cocci. So gram-negative bacilli commonly implicated include E. coli, Klebsiella, Proteus, Enterobacter, Pseudomonas. This is definitely in the order of occurrence. That is, the most common cause for UTI, community-acquired UTI, is E. coli. The second cause would be Klebsiella. Third would be Proteus. This is in the order of occurrence. So kindly when you write no, if not, if it is a hospital acquired infection, probably you can write the first cause as Pseudomonas. Okay, but this is not a hospital acquired in UTI. So therefore, you got to write E. coli, Klebsiella, Proteus. Invariably, when students write Pseudomonas, Enterobacter to begin with and forget to write E. coli and Klebsiella, they are not giving a good impression. They may not get good marks. Right? Then gram-positive cocci include Staphylococcus aureus, Staphylococcus saprophyticus, sometimes Epidermidis, as well as Enterococcus. These are all the gram-positive cocci known to cause urinary tract infections. So pathogenesis, under that you got to describe the risk factors. The risk factors include the age. Elderly individuals are more likely to have UTI. The reasons are different in male and female. In males, it may be because of benign prostatic hypertrophy, whereas in females, it is because of the postmenopausal, the sphincter control also will reduce. Then female gender itself, because of the shorter urethra, there's a possibility of perineal contamination with the intestinal flora, right? Then you have pregnancy, wherein there is decreased emptying as well of the urine also because of the pressure of the growing uterus over the bladder. Then any kind of urinary tract obstructions like BPH or in the form of formation of calculi, renal calculi can also come in the way of UTI. Diabetes is also another risk factor. What you got to observe here is most of the students, whenever they are asked what are the risk factors for UTI, they start with immunocompromised condition, HIV. These things usually do not go well with UTI, right? So please avoid telling immunocompromised status and HIV as a risk factor for UTI, right? They may be a very rare, but there are much more common risk factors. So don't utter those things to begin with, like HIV or a immunosuppressant condition as the risk factor for UTI. So classification is UTI can be classified into ascending as well as descending. Ascending UTI, the route of entry of bacterium, as the name goes, it moves upwards, that is from the urethral meatus towards the bladder. So therefore, to begin with, you'll have urethritis, then you have cystitis, then it moves upwards, right? Whereas descending UTI, it is coming down from the kidney to the bladder. So this is bit rarer. Descending UTI is commonly seen in case of systemic infections, right? When in case of pyonephritis, all those cases, you'll have descending UTI. So here there is presence of bacteria in the bloodstream. Coming to the lab diagnosis of UTI, so sample collection. So this heading you have to mention, this is very important with respect to UTI, because unlike the other samples, here when you collect the sample, you are asking for clean catch midstream. Sample needs to be collected in a sterile wide mouth container, right? The reason for midstream urine collection is mainly because you got to flush out the commensal bacteria that is present in the tract, right? Urinary tract usually harbors the commensal flora. So you have to allow the first stream of urine to pass and then collect the midstream of urine that comes, which will represent the urine that was there in the bladder. Okay, this is applicable in most of the UTIs except for the cases of urethritis, right? Because in case of urethritis, you got to know the organism which is present in a urethra only. There it is indicated to collect the first part of the urine. Okay, and usually it is recommended early morning sample is collected because it is a concentrated urine. But never mind, if early morning sample cannot be collected, that is fine. But other thing is very important, that clean catch midstream urine in a wide mouth container needs to be collected. So usually it should be collected after cleansing the genital parts and then void it into the collection port. Okay, in case of catheterized patients, urine should be collected from the catheter. There will be a port in the catheter separately for collection of the urine, never from the urosac bag. Okay, so it is not recommended to collect from the bag. This needs to be mentioned specifically in case if the patient is mentioned as catheterized in the history. Then transportation, the sample that is collected should be transported to the lab as early as possible, usually within 2 hours. If delay it anticipated, then it has to be kept in the refrigerator, right? That is between 2 to 8 degrees Celsius in the refrigerator. Microscopic examination includes wet mount examination to look for the presence of the pus cells as well as the bacteria. Gram stain also will reveal the presence of pus cells and bacteria. Culture media usually commonly used for urinary tract infection include blood agar, McConkey agar as well as CLED. That is cysteine lysine electrolyte deficient agar, CLED agar is used. Then you have to write about the concept of significant bacteriuria, right? So any answer for a UTI should definitely include the topic about significant bacteriuria. Significant bacteriuria refers to the presence of bacterial growth more than 10 power 5 CFU, that is colony forming unit per ml of the urine. Okay. So significant bacteriuria, many a times it itself has appeared as a short notes question 2. This is applicable only for gram-negative bacilli. That is, if gram-negative bacilli are growing on the plate, their colony count should be more than 10 power 5 CFU. Many a times students forget to mention the unit. They just mention more than 10 power 5. So it is doesn't indicate anything. CFU per ml is the unit is also more important. Then isolation of more than 3 types of bacteria are less than significant number implies there is contamination. That is, if anything less than 10 power 5 is there, usually it is not regarded as a significant growth. This is mainly because commensals will be there and there could be delay in the processing of the sample. That is why this cutoff of more than 10 power 5 is kept. And more than 3 types of bacteria is also indicative of contamination. 3 types means if it is E. coli, Klebsiella, Proteus, and Staph, 4 are there, then it is clearly indicative of contamination, right? So usually the report you'll get only if it is less than 3 types. Most of the time it is single type of the bacteria which is causing UTI. So the recommended antimicrobials for treating UTI or for testing for that matter, it includes ampicillin, amoxicillin, clavulanic acid, cefalexin, norfloxacin, nitrofurantoin, cotrimoxazole. So depending on whether it is a gram negative or a gram positive isolate. Okay. So usually the miss not here antibiotic is the fluoroquinolones, that is norfloxacin, and then nitrofurantoin, cotrimoxazole. These three are usually not to be missed for testing. So coming to another short notes question, that is implications of significant bacteriuria. This can be a part of a long question also. What are the implications? So first, coming to the definition, significant bacteriuria is a term used to differentiate true infection from levels indicative of contamination. That is why this term has come. Presence of more than 10 power 5 CFU ml of voided urine represents significant bacteriuria. Interpretation of bacteria should always be done with reference to the clinical condition of the patient. Why I am telling clinical condition of the patient is because many a times this number, this more than 10 power 5 is not applicable in case if the patient has following conditions. That is, the lower colony count, that is less than 10 power 5, is also significant in case if the patient is already put on antibiotics, right? Early institution of antibiotic therapy, there's a high chance of colony count falling down. So in that way, it is significant. Or if the patient is on diuretics, so there is diuresis, dilution of the urine. So therefore, the colony count may be less per ml. So patients on antibiotics, patients on diuretics, in case of gram-positive bacteria, example, Staphylococcus aureus. So I've said that the concept of significant bacteriuria is applicable only for gram-negative bacilli. For gram-positive organisms, this concept is not applicable. Even for Candida species also, you don't look into more than 10 power 5. That means what? Any number of growth is significant. Even if it is 10 power 2 or 10 power 3 also, it is significant. Okay. Then in case of suprapubic aspirate, that is if urine sample has been collected through suprapubic aspiration, that is directly you are taking from the bladder, then there is no role for commensal being present in the urine, right? So therefore, lower number is also significant. And usually in case of cystitis, this number is not to be taken. Then isolation of more than 3 types of bacteria from a clean catch midstream urine specimen is almost always indicative of contamination. So in such cases, what needs to be done? A repeat sample is recommended, right? Usually if it is 2 or more organism only, we recommend to take a second sample and look for there is again presence of the organism or not. Patients with long-term catheterization with more than 2 organisms present at counts greater than 10 power 5 may be risk for polymicrobic bacteremia. That is, UTI may go in for bacteremia. Coming to the other short notes question, this is from the genitourinary tract, right? So lymphogranuloma venerum. So this is a sexually transmitted infection caused by Chlamydia trachomatis types L1, L2, L3, right? So it's a sexually transmitted disease caused by LGV, that is lymphogranuloma veneromas serovars of Chlamydia trachomatis L1, L2, L3. The incubation period is short, less than a week's time. So it is an acute disease. So this organism, Chlamydia trachomatis, as it gets entered into the body through sexual contact, they multiply in the regional lymph nodes, mainly the inguinal lymph nodes. Later on, the features include there is a small painless papillovesicular lesion appearing on the external genitalia spread to the lymph nodes. This can result in hemorrhagic proctitis with regional lymphadenitis, enlargement of the nodes, that is lymph nodes, suppression, formation of sinus, and discharge of the pus can also occur. This is the clinical feature. Complications include there is scarring. When there is a healing of the ulcer, it may heal with scarring. This can result in blockage of the lymphatic channels. So involvement of the anal canal will result in rectal strictures, as well as it can result in accumulation of lymph because of this scarring over the vulva. This is known as osteomean in case of females. Lab diagnosis include the samples that needs to be collected is the pus samples from the enlarged lymph nodes, that is aspirated buboes. Smears prepared will demonstrate the presence of elementary bodies. You know, chlamydia has got elementary and reticulate bodies, right? So elementary bodies are the ones which can be seen in the smears, that is Miyagawa granulocorpuscles are seen, but this is difficult to demonstrate. The serological tests include complement fixation test, that is abbreviated here as CFT, wherein titer of 1 in 64 is significant, or microimmunofluorescence test, wherein titer of more than 1 in 512 is indicative. Fry's test is a skin test which is used for lymphogranuloma venerum. It's an obsolete test, just for completion's sake it is given. It's a skin test. Then treatment of choice is tetracycline as well as doxycycline can be given. This is what is expected for a short notes on lymphogranuloma venerum. Everything is written in brief. We can see the causative organism, pathogenesis is given as incubation period, what happens, clinical features, complications, lab diagnosis, as well as the treatment. Okay, let's get to the next question, that is pathogenesis and lab diagnosis of cryptococcal meningitis. So this usually occurs as a short notes, or sometimes this can have direct question, or it may be along with the history. The history usually has some immunodeficient condition in a patient. Maybe like they may directly give us a HIV positive individual comes with features of meningitis, right? So HIV positive with features of meningitis, you got to think about cryptococcal meningitis. Or sometimes the question may also indicate that CSF sample was collected and Indiaing preparation was done, capsulated budding yeast cells were seen. They can give like that, or they can even give the question as yeast cells were grown on the agar, SDA agar. Fine. So the pathogenesis include the causative organism is Cryptococcus neoformans. The source of infection is usually this yeast is present in the soil that is rich with pigeon droppings, right? So soil contaminated with the pigeon droppings. The mode of infection is through the inhalation. The virulence factors include the mucopolysaccharide capsule as well as the melanin that is produced. The morphology is like they produce round budding yeast cells which are about 5 to 20 microns with the presence of the capsule. So they are transmitted by inhalation. Generally, they cause asymptomatic infection. The disease is more commonly seen in immunocompromised host. So usually, since it is an opportunistic infection, they can begin with involvement of the lungs as pneumonitis. Then usually they causes meningitis. Sometimes they can have cutaneous manifestations also. Coming to the laboratory diagnosis, the samples that needs to be collected is, in case if it is a cryptococcal meningitis, we mention it as CSF sample. In case the question is pathogenesis and lab diagnosis of cryptococcosis. So if it is not mentioned as cryptococcal meningitis, just cryptococcosis, then you have to keep your thing as broad. Cryptococcosis may involve lungs as well as meninges commonly, rarely as skin. So depending on that, the sample collected will be different. Meningitis is CSF. If it is lung involvement, you tell it is sputum involvement. If it is cutaneous manifestations, you tell skin scrapings. In case of meningitis, there will be bloodstream involvement too. Therefore, you can collect both CSF as well as blood in cryptococcal meningitis. Microscopy of the CSF sample usually shows with the gram stain, gram positive budding yeast cells are seen. Indiaing preparation shows capsulated yeast cells. Culture on seborrheic dextrose agar, you'll find mucoid cream colored colonies. Some of the identification test, that is whether the colony that is grown on seborrheic dextrose agar is cryptococci or not. We can do urease test, and growth on birdseed agar will produce a brown or a black colony due to the present formation of melanin production of the fungi. And then latex agglutination test using the CSF sample. This is a rapid test looking for the presence of the capsular antigen, right? Then PCR is also available. One test of theoretical importance is animal inoculation test, which was done for the demonstration of pathogenicity earlier. That is, culture is inoculated through the intracerebral route into the Swiss albino mice. Then autopsy, you'll find the findings. So next question is, how do you manage a case of dog bite? So when you look into this question, so the diagnosis is not given. It is clearly indicative that a dog bite in an Indian scenario will cause rabies is the first common disease, right? So it is an indirect question asking about management of rabies. So let's look into the answer. So the first and foremost thing you got to do following a dog bite, whether the individual is vaccinated earlier or not vaccinated, is to wash the bite wound with soap and flowing water immediately. So why you need to use flowing water is it will clear the dirt, organic debris, as well as flush out the viruses also. Soap is important because since rabies, that is rhabdoviridae, is a virus with capsule, right? It has got a covering over that, which is lipid. So it can be removed with the help of soap. That is the reason why soap has to be used. After washing the wound is treated with quaternary ammonium compound or tincture iodine or alcohol. Then animal is to be, that is the dog which is bitten, if possible, should be washed for the next 10 days. So usually it is said that the rabid animal will die within 10 days time. That is the reason it is watched. Okay. Then next step involves active immunization along with passive immunization. This depending upon the grade of the bite, right? You have WHO classification classifying into 3 grades, right? Wherein this there is mere licking or something like that. Second is bite is there, but there is no oozing. Then second is there is a oozing of blood also is there. So depending upon the stage of the disease, you got to give active combined with passive immunization. Active immunization currently that is followed, usually what is expected is currently what vaccine is followed, vaccination, that is what is expected out of you. You are not required to write about the neurological vaccines, neuro vaccines that were used earlier, right? Now, these days, whatever is used is common is the tissue culture vaccines that include human diploid cell strain vaccines that is used, which are antigenic free from side effects. And then you have purified chick embryo cell vaccines. These are also free from side effects, bit cheaper also. And then you have purified vero cell vaccine. They are highly antigenic, cheaper, as well as free from side effects. Then you got to write the schedule. Schedule is you have both the schedules like IM as well as ID. In the slide, ID schedule is not mentioned. That's intradermal. Intradermal schedule also you got to write, and intramuscular schedule also, and the location where you're going to give the injection. That is mainly in case of adult, it is to the deltoid region, and in case of children, it is to the anterolateral aspect of the thigh. You have to avoid gluteal region in case of thigh because the vaccine is not effective because immune cells are not present, right? That is the reason. So then passive immunization includes use of immunoglobulin. It could be either human rabies immunoglobulin or equine immunoglobulin, right? Equine rabies immunoglobulin, you will give double of this, that is 40 international unit per kg, whereas human rabies immunoglobulin 20 international unit per kg is given. So you have to calculate depending upon the weight of the individual what is the total immunoglobulin required, and half of that should be given around the site of the wound and remaining half is given to the gluteal region. So immunoglobulin can be given to the gluteal region, not the vaccine, right? And it has to be given simultaneously. Okay. Coming to the next question. This is a long question. A 3-year-old male child was admitted with history of high-grade fever, projectile vomiting, and convulsions. On examination, the child had pale, blotchy skin, stiff neck, and arched back. What is the diagnosis? So the diagnosis is like you have projectile vomiting, fever, convulsions in a 3-year-old. It's in acute onset with stiff neck. It is indicative of meningitis, right? Diagnosis is clearly indicative of meningitis. You have some features in the skin that is had a pale, blotchy skin, some rashes are there. So meningitis with skin rashes, it is indicative of meningococcal meningitis, right? Then classification of the above condition based on the pathogenesis means acute, chronic, like that you have the meningitis. What are the etiological agents and lab diagnosis? We'll see in the next slide. So it's a case of meningitis. The classification is you have acute pyogenic meningitis, which is usually bacterial, chronic meningitis, bacterial, usually tubercular meningitis or chronic meningitis. Subacute also you have, that is in case of cryptococcal meningitis, the presentation is subacute, and some viruses you have aseptic meningitis to occur, right? Etiology, it's written bacterial is commonest causes for meningitis include Haemophilus influenza, Streptococcus, pneumoniae, Neisseria meningitidis, E. coli, Group B Streptococcus, Listeria monocytogenes. Amongst this, there are few of the agents which can cause neonatal meningitis, right? So neonatal meningitis include E. coli, Group B Streptococcus, and Listeria. These three cause neonatal meningitis, that is meningitis occurring in first 1 month of life, right? After that, the agents will change, that is it could be Haemophilus, meningococci, pneumococci. Okay, so you got to know the distinction between the two. In case if the question is on neonatal meningitis, you have to write the last three: E. coli, Group B, and Listeria. This is mainly because this E. coli, Group B, Strepto, Listeria, monocytogenes are more likely to be in the maternal genital tract, right? That is why they are more likely to cause neonatal meningitis. Then you have Mycobacterium tuberculosis, which is known to cause chronic meningitis. Then viral agents which causes aseptic meningitis include enteroviruses, paramyxovirus, herpes virus, adenovirus. Fungi, usual reason is Cryptococcus neoformans. Sometimes Candida albicans can also cause meningitis. Usually as a hospital-acquired infection following a surgery or a trauma, Candida can be there. Then parasites that can cause aseptic meningitis, sometimes encephalitis too. These include the free-living amoeba, Eglaria fowleri, Acanthamoeba, Toxoplasma gondii, and Angiostrongylus cantonensis. These are the parasites which can cause meningitis or encephalitis. Describe the pathogenesis, lab diagnosis, and prophylaxis of meningococcal meningitis. So the history is almost same. This history is also indicative of meningococcal meningitis, but however, it has not said, it is only asked, what is your diagnosis? This is a direct question telling prophylaxis of meningococcal meningitis, asking for pathogenesis as well as lab diagnosis. Let's look to the pathogenesis of meningococcal meningitis. So meningococcal meningitis, it spreads through the airborne droplets mode of infection. The source is usually the patient's carriers who carry meningococci in the nasopharynx, right? They are the source of infection. Route of spread is usually from the nasopharynx through the cribriform plate. It passes through and reaches the blood stream. The complications that can ensue is meningococcemia, that is the presence of meningococci in the blood, which is known as Waterhouse-Friderichsen syndrome. Then it can also cause disseminated coagulation. Pathogens include, it acts by production of endotoxins. Lab diagnosis include samples. Samples is usually the CSF sample needs to be collected, followed by blood, exudates or swab in case if there is a presence of petechial skin lesions. Then nasopharyngeal swab in case of carriers. This swab needs to be transported through the Stewart's medium. So this is for the carriers. The CSF following sterile precautions has to be collected by lumbar puncture. Then whatever CSF that is collected should be transported in a sterile screw-capped containers. It has to be sent to 3 labs, that is pathology, biochemistry, and microbiology. Pathology mainly for the cell count analysis, biochemistry for looking into the proteins and sugars. You know that looking at the proteins and sugars, we can differentiate the etiology of the meningitis, whether this is bacterial, viral, or tubercular. Then for microbiology, you have to send it for identification of the organism as well as the antibiotic susceptibility pattern. So within the microbiology laboratory, we'll look into, so once the CSF is reached, it is divided into 3 parts. So it is first centrifuged. Then after the centrifuge, 3 parts are divided. The upper part is the supernatant. Supernatant part is used for antigen detection and the deposit is used for the gram stain. The second part is given for the culture. Third part is incubated. If the culture is negative, may be used for PCR and other diagnostic test, right? So the microscopy involves first gram stain, looking for the presence of the pus cells and the appearance depending upon the organism which is causing meningitis. Here it is meningococcal meningitis. So therefore you can find gram negative diplococci both within the pus cells as well as outside the pus cells, that is intracellular and extracellular location. Culture medium usually used is blood agar, chocolate agar. Biochemical tests include catalase test, oxidase test. The important biochemicals for identification include glucose, maltose, which are utilized with acid production. Whereas with gonococci, it is only the glucose. Since meningococci is a capsulated organism, you can demonstrate the presence of the capsules by latex agglutination test using the CSF sample. This is one of the rapid tests for diagnosis of meningococcal meningitis. Then PCR can also be employed. A blood culture in case meningococcemia is suspected. So treatment include intravenous penicillin is the drug of choice. In case if there is allergy to penicillin, cephalosporins can be used. Mainly third or fourth generation cephalosporin is of choice because penetration through the blood-brain barrier is good. Then prophylaxis include chemo as well as immunoprophylaxis. Chemoprophylaxis is given with rifampicin or ciprofloxacin. This is indicated in case if there are other susceptible individuals in the same home, right? Usually meningococcal meningitis can occur as an outbreak in case of hostels and other places where there is a closed community, right? Immunoprophylaxis, that is use of vaccines. Vaccines could be either monovalent or a polyvalent vaccine. They are available for the following serotypes, that is capsular polysaccharides of group A, C, Y, and W135. So vaccine is active against this. These are all the common serotypes which are known to cause meningococcal meningitis. So coming to the etiology and lab diagnosis of pyogenic meningitis. So this is more wider than meningococcal meningitis, right? So etiology is same. The agents that causes meningitis that include Haemophilus influenza, pneumococci, meningococci, then Staphylococcus, E. coli, Klebsiella. In the neonates, it is Streptococcus and Listeria. Lab diagnosis is same. That is sample is CSF. CSF sample should not be refrigerated. Blood culture can be done for Neisseria species. Then routine CSF examination, biochemical examination, biochemistry is mainly for looking for the presence of sugars and proteins. You know that in case of pyogenic meningitis, the level of sugar will fall down and proteins will be elevated much. Whereas in case of viral etiology of meningitis, there is not much fall in the sugar. Protein also will increase to a moderate level, right? Then gram stain includes the picture depending upon the organism. So it is a gram-positive diplococci, lanceolated and capsulated. This is in case of Streptococcus pneumoniae. In case of meningococci, you'll find gram-negative diplococci. If it is Staphylococcus, it is gram-positive cocci in clusters. If it is a gram-negative bacilli causing meningitis, that is E. coli, Klebsiella, Haemophilus influenza, you can find a gram-negative bacilli. Group E Streptococcus, that is neonatal meningitis, you'll find gram-positive cocci in chains. Listeria monocytogenes is a gram-positive bacilli. Since the question here is about pyogenic meningitis, you have to describe the commonest morphology of the organism known to cause meningitis, right? Because in our etiology, we have Haemophilus, Streptococcus, Neisseria, E. coli. So you have to describe their morphology in the gram stain. If the question is meningococcal meningitis, that is highly specific question. You can only describe about the appearance of meningococci. Clear? CSF culture include blood agar, chocolate agar, and Bernhardt infusion broth. Then you can do latex agglutination test for the detection of the antigen over the capsule. So besides meningococci, other capsulated organism in the list which can cause meningitis include Haemophilus influenza as well as pneumococci. So you have a latex agglutination test looking for the presence of capsular antigen of Haemophilus influenza, Streptococcus pneumoniae, and meningococci. And one more thing you always have to remember is Haemophilus influenza is a bacteria. Students always confuse whenever it is asked name some viruses causing respiratory tract infection, they tell Haemophilus influenza, which is not a virus, right? It's a bacteria. Influenza is a virus. Influenza and para-influenza is a virus. That distinction you have to make. And coming to pneumococci, right? Pneumococci is known to cause middle ear infection, otitis media, sinusitis, pneumonia, tracheobronchitis, empyema, as well as meningitis. So many a times you may get a long question like a 40-year-old male alcoholic presented with features of meningitis. So then most probable etiological agent would be pneumococci. This is mainly because when they tell alcoholic and all, they are giving a clue that he would have fell unconscious somewhere, and later on developing as aspiration pneumonia, going in for meningitis or aspiration pneumonia itself, because streptococcus pneumonia can occur as a commensal flora in the upper respiratory tract, right? When you are not in a conscious state, the reflexes will go down. The protective reflexes, no airway reflexes will be down. There is a more probability of aspiration. So the organisms that are implicated in aspiration common is pneumonia, streptococcus pneumoniae or pneumococci. Or sometimes you may also get a pneumococcal meningitis as a question or pneumonia. So that's why I've put this. So pathogenesis and lab diagnosis will see. So the lab diagnosis of pneumonia, depending upon what, if it is a pneumonia, you got to collect the sample as sputum. Whereas if it is meningitis, the sample that needs to collect CSF. But however, the gram stain picture will be same. That is, they occur as gram-positive cocci, which is lanceolate in shape in pairs. Okay. And the sputum appearance will be rusty in case of pneumonia. The culture on the blood agar, usually they produce a dome-shaped alpha hemolytic colonies, which on further incubation becomes flat. This is termed as Draughtsman or a carom coin appearance. This is for pneumococci. This will remain same again if it is a pneumococcal meningitis or pneumonia. In case of otitis media, this can be demonstrated from the fluid that is aspirated from the ear, whereas in meningitis, you have to take the CSF sample. Quelling's reaction, this is when pneumococci, that is a sample CSF or a sputum, is mixed with a specific antipolysaccharide serum of the same type or with polyvalent antiserum on a microscope side. The capsule appears to be swollen. The organism agglutinate by cross-linking of the antibodies. This is Quelling's reaction. Then the detection of the polysaccharide capsule can be done by latex agglutination test. Besides this, once it has been grown on the media, you can use identification test as bile solubility test. Bile solubility test is positive for pneumococci and it is optogene sensitive. ELISA and PCR can also be employed. Okay. Next question. How do you manage a patient coming with history of high-grade fever, headache, neck and stiffness for the past 3 days? So this is a case of acute meningitis. How to manage is, since it's a meningitis is a serious condition, you have to admit the patient, then the take cultures. So samples that needs to be collected for a meningitis cases, CSF as well as the blood for culture. Immediately start with empirical antibiotic therapy. You need not wait for culture and sensitivity report, right? What is the drug of choice in that cases? We don't know the organism. Empirical treatment is surge and cephalosporin, injections, ceftriaxone. Then do the gram stain from the CSF sample, look into that and grow in for culture, that is blood agar, chocolate agar, McConkey agar. Biochemicals are used to identify the organism. AST for antibiotic sensitivity and testing. Once report is available, the antibiotic therapy can be adjusted according to the report. Okay. Next question. A 6-year-old boy develops fever and headache. He is taken to the emergency room where he is noted to have a petechial rash over his chest. He also has stiffness, suggesting meningeal irritation. Lumbar puncture is done and CSF shows gram-negative cocci arranged in pairs. So it is clearly evident it's a question on meningococcal meningitis, right? The catch points here is that it is telling its features of meningitis with rash, right? So, and then you have gram-negative cocci arranged in pairs. Gram-negative cocci also is indicative of meningococci. So we have seen the answers already. Pathogenesis, lab diagnosis. So this is Neisseria meningitidis. I've already described pathogenesis is meningococci inhabits the nasopharynx. Dissemination occurs in a small group of people. Spreads from nasopharynx to meninges along the olfactory nerve. So then passes through the cilibriform plate to the subarachnoid space and then through the bloodstream. Meningococcemia occurs. This is the reason for fever, chills, and petechial rash. The fatal condition is Werter-Hausen-Friderichsen syndrome. This may result in shock and DIC. Lab diagnosis include collection of samples, CSF, blood, exudates, and for carriers, naropharyngeal swab. This is same as the earlier question. So antibiotic of choice is IV penicillin is a drug of choice. In case if person is allergic, then you can give injections. Ceftriaxone can be given. Then during epidemics, the carrier rate goes very high. So rifampicin or chloramphenicol or minocycline be given for chemoprophylaxis, or you have immunoprophylaxis vaccines are to be given. Okay. Coming to leptospirosis, this sometimes appears as a long question, sometimes as a short note question. It's a zoonotic disease. So usually you have like it's a Leptospira interrogens is a commonest pathogen. There are other species also like Biflexa, it's a non-pathogenic species. It's a spirochete with the hook at both the ends, like umbrella handle. Then since it's a spirochete, it has been seen under dark field microscopy. Pathogenesis include the source of infection is the rats. So usually they are discharged in the rat urine into the water and other surroundings. When the person comes in contact with the contaminated water, which has got these leptospires contaminated with the rat urine and the skin is broken, it can get into the body or through the contact with the mucous membranes like mouth, nose, and conjunctiva. Incubation period is slightly longer, that is more than 1 week's time. It has two phases, initial phase and secondary phase. Initial phase is wherein the leptospires enters the bloodstream and establishes into the internal organs like liver and kidney, producing hemorrhage and necrosis of the tissue and jaundice. It is not a must that all cases of leptospirosis will have jaundice. Anecteric and icteric, both the types of leptospirosis are there. Serious form of leptospirosis also known as Wales disease. So many a times the short notes may come as Wales disease, that is WEIL. Yes, Wales disease, which is also a icteric leptospirosis, serious form of leptospirosis. Many infections are subclinical. Hepatitis is a frequent in patients with leptospirosis. Coming to the lab diagnosis of leptospirosis, the sample that needs to be collected is blood sample and urine sample. Sometimes with CNS manifestation, CSF sample needs to be collected. Microscopy, dark field examination, look for the presence of the spirochetes. You can also do gypsa staining, fluorescent conjugated antibody staining, and histochemical techniques. Culture media include Fletcher's medium, Kothov's medium, EMGH medium, animal inoculation technique. Serology is the mainstay in the diagnosis of leptospirosis. Practically, if you're speaking, you have two tests, microscopic agglutination test and macroscopic agglutination test. Microscopic agglutination test is the gold standard test, but however, it is present only in the reference center because of the need to use live organisms. It is highly specific, whereas skilled suspensions can be used for macroscopic agglutination test. ELISA is commonly employed. Look for the presence of the IgM immunoglobulins. Treatment is with the use of penicillin, tetracycline, doxycycline. So prophylaxis by prevent exposure to the contaminated water and reducing contamination by rodent control. So usually you will have a history of cyclone or some flooding and then patients presenting with fever, jaundice and all. It is indicative of leptospirosis. It is common seen following famine and flooding. Enumerate 4 bacterial zoonotic diseases. Add a note on malignant pustule. So bacterial zoonotic disease, this include anthrax, brucellosis, plague, leptospirosis. Malignant pustule is skin manifestation of anthrax, right? So malignant pustule is also known as cutaneous anthrax or a Hyde-Porter's disease. So infection occurs following entry of the bacilli through the skin, common on the hands, arms, legs. After 1 to 3 days, vesicle develops containing clear fluid or blood. Whole area is congested and edematous and satellite lesions are formed. This is characterized the formation of HR. HR is something which is very crucial. You have to tell. Then pathogenesis is there is production of toxins. The toxin in anthrax is tripartite. That is 3 parts is there. It has got edema factor, lethal factor, and protective factor. This is something different from the other toxins. Other than toxin, it also has got capsule. Okay, lab diagnosis include microscopy, that is demonstration of gram-positive bacilli, then McFadden's reaction, then direct fluorescent antibody test. Culture you have to mention. You need not describe, just if you mention the names, it's fine. Medusa appearance, inverted fur tree appearance in gelatin slab culture, selective media like PLET medium, inoculation test, serological test, that is Ascolis thermoprecipitant test, which is obsolete now. Antibody detection by ELISA is a commonly done test, as well as complement fixation test. Last is the PCR, looking for the presence of the gene. This much you have to write for a short notes on malignant pustule. Then besides that, in case if it is asked as a biological warfare agent, because it can be used as a biological warfare agent also, anthrax produces the spores. So in that cases, you have to write just like presumptive identification is done by gram-positive bacilli, non-motile, non-hemolytic, catalase positive colonies on blood agar. This is presumptive identification. Initial confirmation you can do in case if it is warfare or biowarfare agent, lysis by gamma phage, direct fluorescent antibody test for the capsule. For epidemiological studies and strain typing, multi-locus variable number tandem repeat analysis can be done, and AFLP can also be done. So pathogens of anthrax. So the source is cattle and sheep act as a source, infected animal. They shed the bacilli in the mouth, nose, as well as the rectum. Valence factors are the capsuline, the anthrax toxin. They causes edema and shock. There are three forms of anthrax: cutaneous anthrax, what I described now. Then you have pulmonary and intestinal anthrax. Pulmonary anthrax is also known as Wool-Sorter's disease. This is through the inhalation of the spores. So it is known to cause hemorrhagic pneumonia, highly fatal, and leads to septicemia. So amongst the three forms of anthrax, highly fatal is the pulmonary anthrax. Intestinal anthrax is rare. It is following ingestion of the carcass of infected animals. It leads to necrotizing enteritis with bloody diarrhea. Okay. Then Wool-Sorter's disease also occurs as the short notes. This is a pulmonary anthrax. Why it is known as Wool-Sorter's disease is because it is commonly seen in workers from wool industries due to inhalation of dust with the spores. So causative agent, source of infection, mode of infection, the virulence factors, these all are same for as for the cutaneous anthrax. Then you have fatal complications resulting in hemorrhagic meningitis and death. Laboratory diagnosis include sputum and blood sample. The tests are almost the same. Okay. Treatment of choice is doxy and ciprofloxacin needs to be given. Coming to plague, pathogenesis of plague, it's a zoonotic disease transmitted by bite of fleas, Xenopsia lacheopis. The two types of plague, urban and sylvatic plague. Urban plague, man, rodents, cat, goat, sheep, that is domestic animals. Sylvatic plague, wild rodents are involved. Three forms, that is bubonic, pneumonic, as well as septicemic plague. Bubonic plague is characterized by fever, malaise. There is mainly involvement of the lymph nodes, often the femoral or inguinal lymph nodes. This is the commonest form of plague. Pneumonic plague occurs with direct inhalation of the pathogen. The syndrome results in productive of bloody sputum and severe pleuritic chest pain. Septicemic plague causes cervical lymphadenopathy, purpura fulminans, and necrosis seen in septicemic plague. Usually, to begin with, most of the cases begin as bubonic plague, then can turn into pneumonic or septicemic plague. Undulant fever, this also occurs as a short notes questions. Undulant fever, the other name is brucellosis, right? So it is caused by Brucella species. Source of infection is the animal products. Mode of infection may be 3 I's: ingestion, inhalation, as well as inoculation. The clinical features of brucellosis could be either acute, chronic, as well as subacute. Disease of the endothelium, mainly it affects the reticuloendothelial system. So therefore, sample collection involves blood, bone marrow, as well as the CSF. Important thing is Castaneda method of blood culture is employed for brucellosis because it takes longer time to grow. The Castaneda method of blood culture involves both liquid and solid medium in the bottle. That is, there is an agar in one side of the blood culture bottle. So when you just tilt the bottle, no, the liquid culture medium will flows over the agar slant, which will help in the growth. Then serological test is commonly employed for brucellosis as standard agglutination test. Short form is SAT. It is referred as. ELISA is commonly employed for detection of IgM antibodies. Other tests used for diagnosis animals, Rose Bengal card test and milk ring test. Treatment include doxycycline streptomycin in adults, cotrimoxazole rifampicin in case of children. This is regarding brucellosis. Q fever, zoonotic disease caused by Coxiella burnetii. Primary reservoir is the bandicoots, transmitted by ixoid ticks. The source of infection is milk, urine, feces. Human infection occurs due to handling of wool, meat, and animal products. So the clinical features include myalgia, pneumonia, endocarditis, hepatitis, meningoencephalitis. You can see that Q fever can affect lungs, heart, liver, as well as the CNS. This is what you got to remember. Lab diagnosis is complement fixation test as well as indirect immunofluorescent assay. Epidemic type. Will take this is more important epidemic type. So the causative agent is Orencia susugamushi. It is seen in South India due to the bite of trombiculide mite. Incubation period is of 3 weeks. Factors for infection is a zoonotic tetrad. Zoonotic tetrad involves presence of the mite Orencia susugamushi chigars, which is the larval form of the mites, rats, and transitional forms of vegetation. Clinical features include the presence of HR, regional lymphadenopathy, fever, headache, conjunctivitis, and rash. Lab diagnosis, Wheel Felix is done, IgM ELISA as well as PCR. Okay, Wheel Felix is one of the heterophile agglutination test. Treatment is doxycycline is the drug of choice. Pyrexia of unknown origin. So you got to know about the definition of PUO. This is taken from the Harrison. Then you have to classify into classic, nosocomial, neutropenic, and HIV associated FUO. All the 3 definitions you need not know. Then etiology of PUO include infections and other diseases. Under infections, what infections can result in PUO, you have to know. Okay, definition, classification, etiology, infective conditions leading to PUO. And then diagnosis can be done by lab investigations, imaging studies, and invasive diagnostic procedures. As far as microbiology is concerned, lab investigations for a case of PUO include blood culture, multiple samples of blood needs to be done. Then peripheral blood smear, if it is a parasitic like malaria, babesia, leishmania. Then agglutination test includes serological test are Vidal test for enteric fever, brucellosis, your standard agglutination test, Wheel Felix test for scrub typhus. Then epidemic typhus also you perform Wheel Felix test. Then bone marrow culture, body fluids culture, urine stool for UTIs, biopsies of the liver if it is hepatitis or something, serological test for the ELISA molecular. This is a general picture of diagnosis of a PUO. Treatment is empirical treatment should be considered for a case of PUO, but if there is no clinical response, stop the therapy and you have to re-evaluate. After definitive culture, AST pattern is available, then treatment has to be modified accordingly. It is discouraged to use steroids to suppress the fever. Pseudomembranous colitis. So it is known to cause, it is also known as antibiotic associated diarrhea caused by Clostridium difficile. So usually is following consumption of antibiotics for a longer period will result in overgrowth of Clostridium difficile, which is present as a commensal in the intestinal tract. Pathogenesis is due to the production of the toxins, right? So most common antibiotics that are implicated in difficile pseudomembranous colitis include the cephalosporins, mainly 2nd and 3rd generation, then ampicillin as well as clindamycin. Least commons are macrolides and penicillins can also. Complications include toxic megacolon, perforation of colon, and fulminant colitis can happen. So lab diagnosis is by enzyme immunoassay as well as real-time PCR. Treatment involves stop all the antibiotics. If there is no relief, even then you can start with metronidazole because it is an anaerobic organism. So therefore metronidazole will work. The route is oral. If still metronidazole is not effective, then you can think of giving vancomycin for 10 days. Actinomycosis. So this usually comes as a short notes. Endogenous infection caused by Actinomyces species presents as multiple abscess. It's a chronic granulomatous disease, causes tissue destruction, formation of sinus resulting in sulfur granules. So presentation may be in the form of cervicofacial, thoracic, abdominal, or pelvic form of actinomycosis. Complications occur due to hematogenous spread to the internal organs. Diagnosis is by microscopy and culture. Microscopy, gram stain of the crushed granules, that is sulfur granules, will show the presence of gram-positive filaments, giving a sun ray appearance. Culture is on Reinhardt infusion broth or thioglycocolate broth. Okay, histopathological examination sulfur granules. Treatment of choice is comoxiclav, ampicillin can be given. So for hospital-acquired infection, you have MRSA. So definition of MRSA, you have to write types of MRSA as hospital-acquired and community-acquired. Then the modes of transmission is mainly through skin-to-skin contact. So therefore, the prevention method is contact precautions has to be taken. Mechanism of drug resistance for MRSA is through the alteration of the MEK gene that is located on SCC, that is staphylococcal cassette chromosome, as well as other mechanism is conversion of penicillin binding to PBP2 to PB2A, which decreases affinity for the drugs. This is the mechanism for methicillin resistance. Right. So definition is the strains of Staphylococcus which are resistant to not only the methicillin, oxacillin as well as sulfoxetine, because usually methicillin is not used for therapy, right? Oxacillin also is not used. It is the cloxacillin that is used for therapy. Risk factors for MRSA are prolonged hospitalization, ICU stay, use of broad spectrum antibiotics, surgical procedures. Other risk factors. Common colonizing sites for MRSA include the anterior nares, axilla, perineum, rectum, groin. So how to diagnose this? Disc diffusion test using a cefoxetine disc or oxacillin disc, or you can do agar screen using oxacillin agar or mannitol salt agar dilution test, E-test, latex agglutination test. Just if you label this test, it's enough. You need not describe how to do the test at UG level. Treatment for MRSA is vancomycin is the drug of choice for MRSA if it is hospital acquired. If it is community acquired, you can try with the other drugs also depending upon the infection it is. If it is skin and soft tissue infection, you can give clindamycin or lesser ones like cotrimoxazole or tetracyclines, etc. For carriers, the treatment is mupirocin ointment is to be given 1%. So 4 common types of hospital-acquired infection. Add a note on measures of control of hospital-acquired infection. So common types of hospital-acquired infection include, catheterization, it is COT, right? So urinary tract infection, then bloodstream infection, that is bacteremia, septicemia. You can also write it as CRBCI, catheter-related bloodstream infections, or CLABSI. Then you have ventilator-associated pneumonia, VAP, and SSI is surgical site infection. These 4 are hospital-acquired infections. So hospital-acquired infection or any infection which was not in incubating period before admission to the hospital. Usual duration is 48 hours, right? Any infection that occurs 48 hours after the admission to the hospital or within 48 hours after the discharge. Then you call it as hospital-acquired infection. Urinary tract infection and also septicemia, ventilator and surgical site infections. So general measures to reduce hospital-acquired infections include hand washing, that is 5 steps of hand hygiene, all those things no? Those things you have tried. Biomedical waste segregation, appropriate use of disinfection, control of MRSA, contact isolation policy, rational use of antibiotics, blood transfusion safety, immunization of the staff. This is for all kinds of hospital-acquired infection, right? Trichomonas vaginalis, this is very simple. You can manage by yourself, I think. But all these things should have diagrams. Without diagrams, you may not get full marks, right? Toxoplasmosis, clinical features. You have to classify into acquired toxoplasmosis and congenital toxoplasmosis and right. Okay, in congenital you have, if it is seen in early months of pregnancy, it leads to abortion or stillbirth. Later months, usually it is asymptomatic. Okay, whereas in acquired toxoplasmosis, it can affect important systems like lungs. It can cause atypical pneumonia, skin rashes. Eye, there is choriorhinitis and anterior uveitis. Heart, it can cause myocarditis. Lab diagnosis include demonstration of the tachycytes and tissue sites. Primary amoebic meningoencephalitis. So this is caused by Naegleria fowleri, which is a free-living amoeba seen in fresh water. So mode of infection is usually through swimming in heavily infected water. So this many a times this can come as a question with a history. That is, some child went for swimming and immediately after coming felt sickness and unconscious or something like that. So this is indicative of primary amoebic meningoencephalitis or Naegleria fowleri. Less common is inhalation also. It has a very, very short incubation period. So it's a neurotropic, spreads to CNS along the olfactory nerves. Inflammation will result in neutrophil and macrophage accumulation and amoeba. Clinical features include acute onset of fever and signs of meningitis, neck stiffness and vomiting, follows a rapid and fatal course. So sample that needs to be collected is wet mount sample, wherein motile trophocytes are amoeba can be seen. Fluorescent antibody stain or right or Giemsa stain is used to demonstrate the presence of amoeba. Culture non-nutrient agar can be used with E. coli. Treatment is amphotericin B and ketoconazole. Neurocysticercosis. This is a question you have to know. Many a times it has asked as a short notes question, important short notes question. So pathogenesis and lab diagnosis, you have to be thorough. That is a mode of infection, pathogenesis. Sometimes life cycle is also asked, right? Oncogenic viruses. So when this question is asked, you have to write the definition and what happens when the cell is infected with the virus, how they transform into oncogenesis. Then we have to write about examples of oncogenic virus, both RNA and DNA virus. This is what is required for this question to answer, oncogenic virus. Fine. Then you have Japanese encephalitis, mainly the pathogenesis. When you write the pathogenesis, you have to write under the heading as the vector, that is Culex tritionirinchus, the reservoir host, amplifier host, then man, it's a dead end of infection, then which place it is present. Japanese encephalitis, certain locality only it is present. The clinical features, usually it is asymptomatic. The clinical case ratio is 500 asymptomatic to 1 clinical cases. Lab diagnosis, nothing much is there actually. So usually it is asked pathogenesis and lab diagnosis. Fine. So pathogenesis and immunoprophylaxis of polio. This is also one of the important questions that is asked as a short notes. Biomedical waste management. So definition, you have to know. Then you have to know the cycle, that is generation of the waste, segregation, collection, storage, transport, treatment, and disposal. This is how it goes about biomedical waste in the hospital. Broader classification is infectious and non-infectious. Non-infectious is further divided into hazardous and non-hazardous. Important thing you got to know is the color codes. So you have to know what articles falls under which one. This many a times this can be asked as a 5-marker question also. And then the disposal, that is disinfection, autoclaving, incineration. These are all the common methods used for disposal. So describe the structure, pathogens, lab diagnosis of HIV. So I've said that HIV can come in bloodstream infections also. Many a times this question can be with a history indicative of a significant loss of weight or history indicative of opportunistic infections, right? Opportunistic infections may be in the form of cryptococcal meningitis or tuberculosis, right? This is a common presentation they can have, or repeated diarrhea, all right? So in the such situations, you will have the questions. So what is the provisional diagnosis means? You have to tell HIV infection. If it is a full blown case, you can write as AIDS. First thing is you have to know the diagram of HIV virus. Labeled diagram is more important. That is labeling of the P24 antigen, GP120, everything you have to write. Then pathogenesis include the types of exposure, modes of transmission. Then in brief is entry of HIV into the bloodstream infects the CD4 cells, RNA transcribed into DNA, that is provirus, reverse transcriptase enzyme happens, then provirus integrates in the host cell genome, latent infection. So therefore HIV infects CD4 cells. There is reversal of the ratio of T4 to T8 cells. So depressed cell immunity, clinical manifestations are due to failure of immune response. This is in very, very brief way it is written. If you can expand and write and further, because here I have not mentioned about the CC4 receptors and all, right? You can write about those things also. Then lab diagnosis include antigen detection, antibody detection. Antigen detection, just if you write like that, you won't get marks. You have to write what antigen is detected, that is P24, when you have to detect it, that is during the earlier phase of the disease or in the very late stage of the disease, right? It coincides with viremia, disappears with antibody production in the circulation, so reappears in the late stage of the disease, so it can be detected by capture ELISA, right? So it is worth this, useful in diagnosis in window period, that is during seronegative, antibody negative cases. Antibody detection, it's the most commonly used, but you can employ this 2 to 8 weeks after the infection. Screening test is high sensitivity and performance antibody detection. That is the one which is commonly done under NACO, right? Then you have rapid test also. Then most important antibodies are those against the envelope glycoproteins, GP120, 160, and GP41. So this antibody detection test will detect antibody against these antigens you have to mention. Then you have the PCR. So the role of PCR is it's a gold standard test at all stages of the disease. DNA PCR and RNA PCR. DNA PCR, you detect proviral DNA. RNA PCR is used for diagnosis and monitoring the viremia. Okay, then you have the isolation of the virus. This is co-cultivation technique. This is not for routine diagnosis, for research purpose only. Then you have the tests which are indicative of prognosis of the disease or more monitoring. This includes CD4 cell count, then PCR as well as P24 antigen. Then you have the non-specific test for HIV. This include leukopenia, reversal of CD4 count, thrombocytopenia, diminished CMI. These are all non-specific tests indicative of HIV infection. Okay. So I hope it was productive for you guys. I was literally a bit fast because it is a revision. So I cannot spend more time in explaining things. Time was short. Okay. Thank you. Kavita?
Hi, sir.
Yes, I've concluded.
Okay. We'll end with
Yes.
Shanti Mantra.
Okay.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः.
Thank you, sir, and thank you, Kavita. It was a nice session. Hope it was useful for the students. If you have any doubts, please ask sir, or you can even post it in the group. Sir and other faculties are there in the group to help you out. Thank you so much,
Yes,
sir, for
definitely.
your valuable
Thank
time.
you. Yeah,
Yes.
thank you, ma'am.